Prevention and treatment of vitamin D deficiency in pediatric practice has emerged as a very controversial area, an area which is often associated with both missing as well as messing up of cases. On one hand, we are seeing situations like infants with neonatal seizures and even dilated cardiomyopathy because of vitamin D deficiency, which are being missed because we are not supplementing infants with enough vitamin D. And on the contrary, we are seeing individuals with vitamin D toxicity because of excessive doses of vitamin D being administered in management of rickets. Therefore, there is a need to develop a effective approach of management and prevention of vitamin D deficiency in which neither of these situations happens, and we have a balanced approach in this regards. The key things to focus in this module would be the what, why and how of vitamin D in pediatric practice. So we'll just begin with what really is vitamin D and why are we so concerned about that. All of us know about the vitamin D cycle, and we know that large amount of vitamin D, probably around 95%, is produced under the UV exposure of sunlight. The peak time for that is approximately between 10 a.m. to 3 p.m. Very minimal amount of vitamin D is actually available from the dietary intake, particularly if we talk about a vegetarian intake. So one needs to take maybe kilos of mushrooms to really get enough vitamin D. And very important to remember that most situations of vitamin D deplete or partially deplete mothers have very limited amount of vitamin D in breast milk. So an infant who is exclusively breastfed, to have enough vitamin D would require to drink something like 20 liters of breast milk to achieve that, which is clearly impossible, emphasizing the need of routine supplementation in this regards. The cholecalciferol, which is the form which is produced by the skin or found in animal sources, or ergocalciferol, which is vitamin D2, which comes from plant sources, are effectively interchangeable in terms of clinical practice and have limited impact. Both of them are converted into 25-hydroxy vitamin D in the liver under the action of enzyme 25-hydroxylase. Now, 25-hydroxylase is a very unique enzyme in that its activity is really dependent upon the substrate, and it is not really having significant feedback inhibition. So the level of 25-hydroxy vitamin D in an individual is actually dependent upon the amount of vitamin D which that individual is deriving either through sunlight or through nutritional sources. Moreover, 25-hydroxy vitamin D has a long half-life and is therefore one of the best and most accurate predictors as far as vitamin D action. 25-dihydroxy vitamin D3 is acted upon by the enzyme 1-alpha hydroxylase in the kidney to produce calcitriol, which is actually the active form of hormone. But the calcitriol is largely regulated by the parathyroid gland, and therefore its level may actually be low, normal or high in the setting of vitamin D deficiency, making it a very useless marker or a situation in which you're wasting money if you're looking for 125-dihydroxy vitamin D in evaluation of vitamin D deficiency. It definitely has role in rare situations of vitamin D resistance or lack of 1-hydroxylase action, but of no role in clinical practice. Now, we all know that calcitriol plays an important role in maintaining the calcium balance of the body by increasing intestinal absorption of calcium. And of late, there have been a huge hue and cry emerging as vitamin D could be panacea to n number of situations with important role with regards to immunity, infection, neural effects, skin and cancer. Having said that, I would say that the decision to treat vitamin D deficiency or to supplement to prevent vitamin deficiency, particularly in children, should largely be based upon the calcemic benefits of vitamin D and not on these putative non-calcemic benefits, which at the moment can best be described as associations and not really a causal link in most situations has been observed. So To look into the picture, the first issue which comes to our mind is how much sunlight is required in terms of production. So if you look at the amount of exposure of sunlight, it would depend upon a number of factors: the latitude, the angle at which the sunlight falls in that particular region, and of course skin color. While it might be quite possible to have a minimal exposure of around 10 to 23 minutes in the Caucasian population to produce enough vitamin D, in our situation the requirements is much more. It is to the tune of 5 to 10 times more compared to the Western population, which unfortunately, especially during these summers and during the excessive exposure of UV rays, may not be possible for most of our children, and this may partially explain the cause of excessive vitamin D deficiency in Indian children. Now the other question is, when should we really worry, and what should be the level of 25-hydroxy vitamin D when one needs to worry? This is a very controversial topic, but I'll try to make it very simple. The decision to decide about a particular cutoff for any biochemical parameters is largely dependent upon the clinical effects that we are looking. So if you look at the 25-hydroxy vitamin D, it is widely considered that levels below 20 nanograms per milliliter are associated with increase in alkaline phosphatase. On the other hand, levels which are more than 100 nanograms per ml are associated with the risk of developing hypercalcemia. Therefore, levels between 20 to 100 can broadly be classified as normal, and those beyond 100 should be considered toxic. The next logical clinical endpoint in this regards is development of rickets, and very elegant studies done many decades ago have clearly shown that vitamin D deficiency rickets is unlikely at a situation where vitamin D levels are beyond 15 nanogram per ml. So therefore, insufficiency is often diagnosed as levels between 15 to 20. From a clinical standpoint, hypocalcemia is also an important point, particularly during early childhood and infancy, in which it has been found that vitamin D levels are usually less than 5 nanogram per ml in children who develop hypocalcemia. So levels below 5 nanograms per ml should be considered as severe deficiency. Now the cutoff that I have been talking about are largely derived from the recommendations by American Academy of Pediatrics, and to complicate the matter further, the Endocrine Society guidelines, which were released in 2011, have a slightly different take, which consider 20 nanogram per mils as the criteria for deficiency and 30 as the criteria for insufficiency. So which cutoff should we use for 25-hydroxy vitamin D to diagnose vitamin D deficiency? If you collate most evidence, one would suspect that maintaining vitamin D levels beyond 20 nanograms per ml is usually sufficient to prevent most clinical problems associated with vitamin D deficiency, and this should be the target that we are looking at. Now we know what really is vitamin D and what is vitamin D deficiency. The next question which comes to mind is, why are we really bothered about this molecule? From a clinical standpoint, I would say calcemic effects of vitamin D deficiency are the most important, and three effects which have to be considered. One which everybody knows is rickets. Second, which is often not very commonly known, is dilated cardiomyopathy, particularly in early childhood. This is an extremely reversible form of cardiac failure, which once treated with calcium and vitamin D can have significant benefit in terms of outcome. And so is the hypocalcemia, which is associated with vitamin D deficiency, which classically occurs around 6 to 12 weeks of life, and it may actually be life-threatening in certain situations. So if one wants to prevent rickets, dilated cardiomyopathy and hypocalcemic seizures, one need to really prevent vitamin D deficiency. What about the non-calcemic benefits? And I would again say that they are more of associations rather than causation. So we can think of allergic diathesis, situations and outcome in the setting of a ICU patient, bronchial asthma, type 1 diabetes, and even cancer have been associated with low vitamin D levels. Whether normalizing vitamin D levels in this setting would result in improvement in clinical outcome remains to be seen. Why are we bothered about vitamin D deficiency in India? Because studies have shown a huge amount of vitamin D deficiency ranging from around 85 to 90% in most individuals, particularly in the neonates, which are the most at risk to develop hypocalcemia, the most important and life-threatening complication of vitamin D deficiency. Studies from AIMS have clearly shown how vitamin D deficiency is extremely common during infancy, and they correlate very well with levels which are found in mothers, and therefore it is important to not only supplement vitamin D in infants but also provide prenatal and antenatal supplementation of vitamin D in mothers to achieve reasonable amount of vitamin D. Now we know why are we bothered about vitamin deficiency. Now how do we go forward in terms of management? Just a few words about the different vitamin D preparations which are available. We are all aware about the active form of vitamin D, which is calcitriol, which is a very potent agent. It requires a very small dose and has a small half-life. The advantage of calcitriol is that it is effective in both individuals with renal and hepatic failure. Because of the short half-life, will be very effective in acute vitamin D deficiency situations like hypocalcemia. But that also results in increased risk of developing complications and hypercalcemia. 1-hydroxy-vitamin D is usually as good as calcitriol, with the exception that it is ineffective in individuals who have defective 25-hydroxylase production or action like chronic liver disease. Vitamin D, either ergocalciferol or cholecalciferol, have the advantage of the long half-life and being deposited in the body fat so that they can really replenish the store of vitamin D, which cannot happen by just the treatment of calcitriol and 1-hydroxy-vitamin D. They are the treatment of choice for chronic vitamin D deficiency. So in terms of, we want to place in terms of treatment, if an individual is asymptomatic, treatment with vitamin D is quite effective, while those who are symptomatic should start off with activated vitamin D analogs and be shifted to conventional vitamin D preparations once those levels have been achieved. Now I'll come down to this case, the 6-month-old boy with respiratory distress who presented with hepatomegaly, had very poor ejection fraction, was diagnosed as dilated cardiomyopathy, started on furosemide in pediatric cardiology ICU. Unfortunately, by the time when the calcium was found to be 5.6 and vitamin D was found to be very low, the child was referred to us, but at that time it was too late. And this was around more than 15 years ago, at a time when the knowledge about hypocalcemic cardiomyopathy was in early infancy, particularly in the setting of vitamin D deficiency. So how could we have really saved this child? And linked to that is that when should we give vitamin D to an individual? In clinical perspective, definitely, as we have discussed, breastfeeding has very limited amount of vitamin D. So therefore, all breastfed individuals should require vitamin D. SGA babies, adolescent age group is a time when there is maximum formation of bones, those who have rickets, malnutrition, and allergy becomes occurring. So routine supplementation of vitamin D, if one was to ask me as to which situation should be given, would definitely be in infants, because that is the time when we want to prevent hypocalcemia and cardiomyopathy, which may be lethal in our setting, and adolescents, because we want to prevent osteoporosis from developing at a later stage of life. Definitely one should have a look at the BMJ Learning module on vitamin D supplementation in infant and children, which provides idea about the dose ranges which should be given for children at different age groups. I would also like to recommend to go through the Endocrine Society Clinical Practice Guidelines about treatment, prevention and evaluation of vitamin deficiency, which very nicely summarizes about pediatric vitamin D. And just to highlight the key aspect of supplementation in children, it really talks about 400 international units as the base dose. If you remember, around a few years ago, 200 international units of vitamin D was considered to be a reasonable dose, but the Endocrine Society now clearly says that the minimum dose required even in infancy is 400 international units, and one may have to go up to 1000 international units to achieve good outcome. What is also important to remember is that there is a wide margin of safety of an upper limit of up to 2000 international units below 1 year and 4000 international units in the remaining part of childhood and adolescence which one can give. There is also emphasis that in special situations like childhood obesity and specific drugs, the requirement may be much more and one needs to give routine vitamin D supplementation in that regards. So two situations in which vitamin D supplementation is definitely required is infancy for prevention of hypocalcemia and adolescence during the period of acquisition of peak bone mass. So what could have been done to prevent these complications in this child? One could have really very easily prevented if we had given both maternal supplementation and neonatal supplementation in this regards. We come on to the second case, which is often a situation of messing up rather than missing. This was a 4-year-old boy with failure to thrive. An X-ray showed rickets. The child went from one specialist to the other. One orthopedician to a pediatrician, was given every time tons of vitamin D. Some would give injectable erythritol. Some would give oral vitamin D. No improvement. And by the time child came to us, the child actually had developed nephrocalcinosis. So what really went wrong in this perspective? And I'll again go forward to the Endocrine Society guidelines as far as treatment is considered. And one needs to be careful that treatment of vitamin D deficiency is not just a single situation where you give vitamin D and forget and don't consider the treatment which has been given earlier. So in most situations in Western countries, it's the daily dose which is recommended. And I would say that children who are less than 1 year of age, if they have vitamin D deficiency, it will be prudent to give once daily vitamin D. Now we have good preparations available which have the concentrations available in the form of drops, which can give up to 800 international units in a ml, so which can be easily given. Beyond infancy, in our setting, it often becomes difficult to give daily vitamin D, and in that regards, weekly doses are something which are recommended. Now coming on to the STOS dose, which is giving a huge dose at a setup and then following up, is something which is falling into disrepute, but still STOS dose should be limited to 1,50,000 units between the ages of 1 to 12 months and usually 3 to 6 lakh international units, so 300,000 to 600,000 international units between 1 to 18 years. One needs to remember that any individual who is being treated with vitamin D deficiency, unless the individual has malabsorption, would respond as well to oral therapy as compared to injectable therapy. Injectable therapy has a risk of developing hypercalcemia at a much higher rate compared to the oral therapy and should therefore be avoided unless somebody is suspecting strongly about the possibility of malabsorption. Calcium deficiency is rampant in Indian children, and unless we give supplementary calcium, we would not expect healing of rickets, and therefore calcium should be given to all individuals with vitamin D. And what is important to remember is that alkaline phosphatase and bone pain are not a good marker of response to therapy because they may actually go up with vitamin D therapy, and one needs to be careful in terms of assessment. So what to do when somebody has encountered with a child with vitamin D deficiency? In that situation, the step and clinical management will depend upon the symptoms. If the child is symptomatic with hypocalcemia, one has to give activated vitamin D and a high dose calcium, which may be required as an intravenous infusion over a period of 2 to 3 days, following which one can start vitamin D and calcium supplement. It's very important to also give vitamin D because activated vitamin D will not increase the body stores of vitamin D and the child will again develop hypocalcemia in that setting. If an individual has low vitamin D and rickets, one has to keep the ear and eyes open about the possibility of refractory rickets and look for signs like polyuria, seizures, fractures and growth failure. If it's very significant, we need to start off working for refractory rickets at that very moment. In the absence of those signs, start of vitamin D, which can be in the form of a daily dose, in the form of a weekly dose of 60,000 international units, or a STOS therapy along with calcium. Look for response after 6 weeks, and remember that the best form of response will be the X-ray, and if X-ray shows a line of healing, which is this white line in the lower limb end, then we should continue with vitamin D at a maintenance dose along with calcium. In the absence of line of healing, one should go forward towards workup for refractory rickets. In the absence of hypocalcemia, rickets, normal alkaline phosphatase, one may actually start off with giving vitamin D alone, but in clinical perspective in India, I would say this would be a rare situation. And in this situation, we should follow up with repeat vitamin D 6 weeks later, and if the levels have normalized, one should switch back to the lower supplementation dose. Otherwise, one needs to continue with higher doses in this regards. So the key in terms of treatment of vitamin D deficiency is to decide about the severity of vitamin D deficiency, to give calcium, and to think of refractory causes at appropriate situations to avoid significant complications. So if you go back to this 4-year-old boy with failure to thrive who received tons of vitamin D resulting in nephrocalcinosis, what could have been done to prevent this was that if we had used lower dose and a workup for refractory rickets would have been done earlier, we could have found this child actually had distal RTA and was not requiring so much vitamin D in this regards. Coming on another case, a 2-year-old boy with rickets, and this child was treated by an orthopedic surgeon who gave 3 injections of ericketol every 15 days, 600,000 international units, and it is not unusual to expect that the child became very irritable, had developed polyuria. Presented to us, we found that the calcium levels were high, so a very high vitamin D level, and this is what is vitamin D toxicity. Vitamin D is a very safe hormone. It has a wide range of safety, but if we abuse it to a great extent, it can do harm. And in this situation, we had to use hydration, furosemide and steroids to really take care of vitamin D toxicity which is happening. This gives us a clear-cut message that unnecessary overdosing of vitamin D is not going to help and can have very, very deleterious side effects in long-term future. So just to summarize, the key issues from this module are that vitamin D deficiency is extremely common in children. This has significant health impact, particularly in calcemic effects like bone mass, rickets, seizures, and hypocalcemic cardiomyopathy. Therefore, important to supplement all infants and adolescents, but we need to be cautious about overzealous treatment of rickets, particularly in children.